Good morning, friends. Dr. Satyaman Sharma, Dr. Shiv Kumar, Srinivas Kumar, Hetan, Dr. Mr. Vara. I call him Dr. Vara Prasad because he has become one of us, and young friends and budding cardiologists. Uh, I welcome you to the 7th edition of this Face the Examiners. There are so many things, as you know, in the research. There's a term called a serendipitous discovery of, say, penicillin, serendipitous discovery of Lasix. Similarly, this particular kind of a teaching program is also serendipitous, and I'll tell you how. It was about 8 or 9 years back, right in Hyderabad. There was a meeting of NIC, and myself and Shiv were having a breakfast on the same table, and suddenly Shiv said, "Sir, what I find, there is a lack of teaching programs for the younger generation as used to be before, and why not we do something?" And while eating breakfast, just came in Mr. Vara Prasad. So I said, somebody has to support it. So, and very willingly, Vara said, well, if your intentions are good and you people want to bring in the faculty to teach, we are ready to pitch in our resources. And that's how it happened. And the first meeting, we held it in Mumbai in collaboration with the Academy of Cardiology at Mumbai and the LTM Medical College. That was my alma mater. That's where I used to teach. And that's how we started. And I never thought that it will go beyond that. But surprisingly, come next year, we had the program right in Apollo Hospital with Shiv Kumar sort of lending his hand, and then it went on. Now it is on an auto mode, because I feel that all the teachers who have been with us, they like it. Students all over the country, they have heard about it. There are people who finance it and support us, and I'm very happy that the younger generation getting an opportunity to learn. We on our part do whatever little bit we can do. I am now a retired teacher. I used to be DM and DNB cardiology examiner. I am no more. So they keep on pulling me in to give my wisdom if I have any left in me now. But I gathered a lot of information, what I've seen students, where they fumble, where they make mistakes. And of course, the way we sort of treat our patients, investigate our patients, as you know, is totally changed. Now it is more technology-oriented diagnosis, technology-oriented treatment. It is not same as it used to be before 20, 30 years back when I used to be teacher and I used to be examiner. So I think there has been change, and my faculty will tell you what changes occurred, how to approach the patient in the context of the new technology, new investigations, new treatment available. And I'm sure next 1.5 days you're going to be enjoying this program. They are brilliant teachers, and I thank all of them who always have given us support. I thank Vara for bringing in his own resources of the company to participate in this program and make this program a great success. I wish you a very good teaching 1.5 day stay in Hyderabad. Thank you very much.
So with that intro, we'll switch gears and we'll directly go on to our academic program first. So the first lecture by Sir, Dr. Pahlajani Sir, is that art and science of case presentation. Because again, Dr. Satyaman Sharma Sir is going to tell art of history taking and clinical approach. So.
This one? here. It's not here. Oh. History taking is really an art. As a matter of fact, if you read the Hippocrates Oath, and in the Hippocrates Oath, Hippocrates has mentioned that thou shalt practice this art. So as a matter of fact, medicine has been to start with, it started as an art. And that art has persisted today. Taking a good history itself is an excellent art. Very few people possess it, but I can tell you one thing, that if you take a good history, practice that art, you will really come to your final diagnosis without much difficulty. Now when you take a history, the history is sort of starts with the presenting symptoms. Now why do we take history? Why do you practice this art? Because actually it is a gateway to make a final diagnosis, to order few investigations, and then to understand the final prognosis of a patient and the treatment that you're going to prescribe. So I think history taking is the most fundamental part of any patient care in our life. Now when you take a history, the first thing is what are the presenting symptoms. And the presenting symptoms guide you how you should proceed further to take the past history, and particularly when you get the cases. Remember what you get in the examination. In the examination you get the cases who have got either rheumatic fever, rheumatic heart disease, they have got a congenital heart disease, or they have got, because of tuberculosis, they have got a constrictive pericarditis, or if they had a chest injury, there is some arteriovenous communication. Very important is to understand the family history, pregnancy, and particularly you must, when you examine a patient, take the history of rubella, because many of the children who are born to a mother who had rubella during pregnancy are born with some congenital defects in the pulmonary arteries. Trisomy is very important because you may get a case who has got an ostium primum defect, has got an AV canal defect and mitral regurgitation, and these are some of the common cases that you will get. Ehlers-Danlos syndrome, you must know the peripheral physical signs, that there is an hyperextensibility of the thumb, the fingers, and these are usually associated with atrial septal defect. Marfan syndrome, features are very straightforward. You see a tall structure man with a long neck, and these patients usually have an aortic valve disease, aortic regurgitation. Turner, remember this, if you see a male, don't diagnose Turner, because as you know, Turner is a single X chromosome disease, and therefore it's a female disease where the physical features are very common, and these patients get usually the aortic disease. And in an adult patient, knowing hypertension, diabetes, drugs. Examiners are very fond of asking you what are the drugs that one takes, is habituated to, which can lead to heart disease. Don't forget cocaine. Cocaine is one drug which is now very rampant, which produces the cardiac issues. So you must remember, they are very fond of asking which is the drug which causes the heart attacks. Alcohol and tobacco, of course, without saying, we must know. As I said, Turner, females, absence of X chromosome, dissection which causes dissection of aorta and blood vessels, Ehlers-Danlos, Marfan syndrome, trisomy which causes Mongolism. Mongol features are very, very straightforward. You see a child, you will straightway make a diagnosis of Mongol, especially a bridge which is depressed, widely placed eyes, the forehead is slightly pointing downwards. It's a very Mongol child is very easy to diagnose, which I'm sure our next speakers are going to tell, and is usually associated with the ostium primum defect or AV canal defect. The most two important symptoms that you, when you practice in your clinic or you see a patient in your exam or in your hospital, are two. Only two symptoms: chest pain and shortness of breath. You must know what are the causes of chest pain and what are the causes of breathlessness and what are the types of cases that we presented to you. And you must know how to grade a chest pain, a stable angina. Every examiner will ask you, how do you grade? What is the grade of the stable angina? And as you know, the term which is, or the classification which is accepted all over the world is called as the Canadian cardiovascular class. Class 1 is mild, class 4 is a very severe type of the anginal symptoms. So you must know by heart the Canadian cardiovascular class examination. Then there are different types of chest pains and angina, and you must know that also, because most of the time they'll ask you in the symptoms, what are the types of chest pains you know? Unstable angina, acute coronary syndrome, myocardial infarction, French metals of vasospastic angina. And then there is a term which is being now accepted, which we used to laugh in our time, is a microvascular angina. So you must know there is an entity called as a microvascular angina. Very important, you will see you will be presented with a case who has got some valvular disease, some congenital heart disease, who have got chest pains. But you must know how to differentiate between the atypical pain that these patients present and a typical angina. So you must know what is the typical angina symptoms like. You must know by heart. The second symptom which I said is the dyspnea or the breathlessness on exertion, paroxysmal nocturnal dyspnea, orthopnea, and there's a fourth type of breathlessness which is being described now. This is called as a bendopnea, where the patient gets breathlessness when he bends forward. It has been described and it has been documented hemodynamically that when a patient bends down, the right atrial pressure goes up and the pulmonary capillary wedge pressure also goes up. So actually in this position, the hemodynamics changes and the patient gets a typical chest pain. Then in the breathlessness, immediately the examiner will ask you a question, how do you classify your breathlessness or effort intolerance? And mind you, today also in every trial of a drug, every trial of a prognosis of a patient, the classification which have withstood the test of time is the New York Heart Association classification. Again, you must know this by heart, class 1, 2, 3. 1 is minimum symptoms, 4 is symptoms on a minimal activity. You must know by heart. Some examiners, and many of them, are very scientific and they like to know from you which is a more objective way of sort of a classifying effort intolerance. And this effort intolerance, which is objectively classified, is called as a specific activity scale. And this measures in the metabolic equivalence, and class 1 is 7 metabolic equivalents or less. Class 4 is patient cannot perform even at 2 metabolic equivalents. So you must know these three classifications: Canadian Heart Association, Cardiovascular Association for angina, and 2 for the effort intolerance. Now, patients get shortness of breath, not only on effort, but they get at night also, what is called as a paroxysmal nocturnal dyspnea and orthopnea. Now, there's a difference between the two. I'll explain to you. You will be asked what is the difference between orthopnea and paroxysmal nocturnal dyspnea. It is mainly because of the depression of respiratory center during sleep, redistribution of body fluids from abdomen to chest, already congested lung in patient in the left heart failure, and some people feel it could be hormonal because of the angiotensin mechanism. Now this I told you that there is a there is definitely an increase in the right atrial pressure in the bendopnea and increase in the pulmonary capillary wedge pressure in patients who get bendopnea. Now this is the difference between the orthopnea and paroxysmal nocturnal dyspnea, and you will get this from the book, but you must know these are totally two different symptoms which you must classify and tell the examiner properly that the patient is either orthopnic or the patient has got a paroxysmal nocturnal dyspnea. For example, PND occurs usually 2 to 3 hours after sleep, whereas orthopnea occurs when the patient is in the recumbent position. That's the one which we call as orthopnea. Now today's time, this was not there in the past, but today's time, if the examiner is sort of a good, he knows one score which every one of you should know, and what is called as a frailty score, because this was not given very importance, but today when we do towers, we do wall replacements, we do surgeries, in that particular treatment format, knowing a frailty score is very important, because then you have to make a choice whether the patient is a good candidate for surgery or whether the patient is a bad candidate for surgery because of the high frailty score and should therefore go for PCI or should go for medical treatment. This is a kind of this is called as Fried criteria, in which there are 5 criteria given, and if the criteria are more than 3, it indicates that the patient is very frail, therefore very poor risk for surgery or poor risk for any procedure. So I think this is one thing which has become very important nowadays. Then, based on the history, if you see a patient who has got hyperdynamic or high output, rheumatic, congenital, normal or low output state arrhythmia like atrial fibrillation or SVT. So I think these things you have to keep in mind. Now, for example, I'll give you a case just to go through quickly. 18 years, female, shortness of breath, palpitation on and off since then, no history of PND, vague joint pains. Now, when you see vague joint pains, immediately you should come to your mind that perhaps you are dealing with a rheumatic heart disease. Palpitations, you possibly think that probably is a high output state case and likely to be a high output state. Therefore, you should think of aortic regurgitation, mitral regurgitation, AP window, PDA, truncus, and rupture of sinus of valsalva. Sometimes these patients with high output can be low output. They may not have palpitations because they may have arrhythmias or if they have cardiac failure. So therefore the output falls. Therefore you may not get the signs of high output state. So you have to go more by physical findings like auscultation, etc. Another case I would tell you where the patient has got palpitations on effort, vague chest pain, but no joint pains. And again, you should think of some high output state. And here, since there is no joint pains and palpitations, possibly it is going to be a congenital heart disease with an high output state, which could be either aortic regurgitation, mitral regurgitation, AV fistula, PDA, AP window, rupture sinus of valsalva, on anything. Very important, many times examiners have seen them asking you edema of feet, but you don't see fine signs of congestive cardiac failure. They'll ask you what is the other cause. Please don't forget to tell them if the patient is on the beta blockers like calcium channel blockers, which could be responsible for this. The second thing, symptom which I said, chest pain, syncopal attack, and determine if it is classical or is it a vague. And if it is classical, you should think of myocardial infarction and its complications. Aortic stenosis can cause very classical angina symptoms, which could mimic like a myocardial infarction, hypertrophic cardiomyopathy and subaortic membrane aortic stenosis. If it is atypical, it is likely to be functional, valvular, pericardial, or pleural. And remember, aortic dissection pain, usually at the back between the scapula. So if the patient complains of pain, please ask him whether the pain is in between the two scapula. That could be because of the aortic dissection. Then coming to, therefore, simple thing. Ultimately what you get in cases, I'll just summarize very few cases. If you memorize these cases and their findings, you got through your DNB and DM. What are the acquired cases that you get? You get combination of MS, MR, MS with AR, MS with TR, MR with AR, MR with AR. You get cardiomyopathies in which they'll ask you whether it is a restrictive cardiomyopathy or hypertrophic obstructive cardiomyopathy, or some common cases like constrictive pericarditis. And when it comes to arthritis, you may get some patients who have got absence of pulses in the lower extremities. It could be polyarthritis and could be with aortic valve or cardiomyopathy. And if you see some common congenital cases, it could be acyanotic and cyanotic. If you get cyanotic, you have to look at, is it a, they'll give X-ray, they'll give ECG, is it a tetralogy physiology? If it is tetralogy physiology, then you have to think of conditions like reduced pulmonary blood flow, tetralogy of fellow, double outlet right ventricle, pulmonary stenosis, tricuspid atresia, TGA with PCA, PS and so on. So I think ultimately if you really see, you get very limited number of cases and you should know the combination of symptoms. Take a good history, learn to elicit a good history and put your patients into the points which are negative for that particular case and then come to a final conclusion. I think learn a good history. I'm sure you will go through your examination. Thank you very much.